Oh, hello. My name's Ian Thompson, and I'm a trainee assistant practitioner for Queen's Hospital Burton's Foundation Trust. This is my case study regarding a patient who came to our A&E with a query infective exacerbation of his COPD. So, who was the patient? Let's review the details. I was handed over a 57-year-old man with a history of asthma and an already confirmed diagnosis of COPD from his GP in the community. He usually manages his COPD at home with inhalers. He's still a smoker, smoking up to 15 to 20 cigarettes a day, and he's also on the obese side with a BMI of above 28. He still works, he's a plasterer and plumber, so with his lifestyle and his job, he's exposed to lots and lots of chemicals that he is breathing in. Once the patient had settled into the ward, I did his observations. He had a resting respiratory rate of 28. He had a saturation level of 85% on room air. His temperature was 37.8. He had a blood pressure of 158/92 and a resting pulse of 95. But what is COPD? COPD, or chronic obstructive pulmonary disease, is often described as limited airflow, often associated with emphysema and bronchitis. This group of conditions makes it difficult for a person to empty the air out properly when they breathe out because of the narrowing of the airways. Bronchitis is when the airway is inflamed. This can cause a person to produce sputum or phlegm. Emphysema affects the air sacs at the end of the airways inside the lungs. These break down and the lungs become loose and full of holes. These processes narrow your airways, making it harder to move air in and out as you breathe. Your lungs are less than able to take in oxygen and get rid of the carbon dioxide. So to break down the initials, C, chronic, meaning it's a long-term illness. O, meaning obstructive, meaning your airways are narrowed, making it harder to breathe out. P, meaning pulmonary, that means it only affects your lungs. And D, for disease, meaning it's a medical condition. In the human body, your airways are lined by muscle and elastic tissue. In a normal lung, the tissue acts by pulling the airways to keep them open. In COPD, the airways are narrowed because of damage, creating less pull on the airways. The elastic lining flops and is also inflamed. So, going back to the patient, how did we treat him? Let's have a look, shall we? So, as an inpatient, we put the patient on a low dose of continuous oxygen to help bring his saturations to above 88%. He was given regular nebulizers. This treatment works by delivering a dose of medication in the form of a mist that is inhaled directly into the lungs. There are obvious things the patient can do at home to aid himself. He could obviously quit smoking. Cigarette smoke damages the air sacs and the airways and the lining of the lungs. Injured lungs have great trouble moving the air in and out, making it harder to breathe in and breathe out. The guy could obviously lose a bit of weight. Obesity is not considered a risk factor for COPD, as it is for other conditions like with your heart. But there is clinical evidence that there is a relationship between obesity and COPD. So, to conclude my video, the patient did go home, but he went home on inhalers and strong antibiotics for his chest infection. He doesn't require home oxygen currently, but he may do in the future if he doesn't quit smoking or even permanently retire from his job. There is no cure for COPD, but you can help prevent getting it by quitting smoking if you are a smoker already, and weight management. So until next time folks, I've been Ian Thompson. Breathe easy.